This week we're going to review the details covered in Domain 4 of the RHIA. This is all about the money. Show me the money. But before we can show you the money, we have to get a few things straight. The revenue cycle begins when the patient comes in over the threshold, whether it's a hospital or a physician's office. And in some cases, you will find that there will be non-face-to-face interaction between clinicians and patients. However, in the hospital, that is not a primary concern. So focus on when activities occur, what activities occur. This encompasses people involved, staff as well as patients. It encompasses equipment, methodologies, and techniques. You need to know all about this. Revenue cycle management has to do with the tracking of a patient, as I said, across the threshold, coming into the facility, and again, crossing the threshold out of the facility. This is going to involve admitting as well as the processes that are involved with that. And whether the patient is admitted through the front door or through the emergency room, or as a result of complications from outpatient surgery, these are all aspects that must be taken into consideration. Case management, charge capture, all of this goes into the proper aspect of revenue cycle management because it all goes into what information we have to include on that claim form or that invoice, and that directly impacts everything else that goes on in the facility, because without money, nothing happens. Revenue cycle management has a life cycle, as do most things. And in our case, we're going to divide this into three parts. There's the front end process that has to do with the establishment of the relationship between the facility or the provider and the payer. The middle process, which has to do with the documentation of all of the details that went on with regard to why the patient needed care and then what specifically was provided. And then the back end, which has to do with the creation and submission of the claims, posting payment accurately, following up on when payment is received, when it's not received. Sometimes we take an attitude about technology and feel that it can be perfect. I sent you an email. Don't tell me you didn't get it. But yet, things happen. There are glitches in systems. So there is a possibility that the reason you did not get the money from that claim is because they never received it. That follow-up has to be part of the process. And then, of course, denial management. Pre-authorization aids and abets a good, healthy revenue cycle. And that has to do with prior approval or authorization. Sometimes it's called pre-certification or predetermination. The bottom line is this is most often used in cases of HMOs. You may also encounter it in a civilian hospital when caring for someone who's covered under TRICARE or the Veterans Administration. But this is essentially contacting the third-party payer and saying, here is the why, here is the what we feel is necessary to do, and we want you to tell us before we do anything if you will cover this, if you will pay for this. This is a proper thing to do because When a patient is recovering from surgery is not really the time to say, and oh, by the way, your insurance company won't pay. You owe us $150,000. That's like going to the grocery store and getting food, taking it home, eating it, and then the grocery store says, oh, by the way, we didn't put the right price or charge you the right amount for that loaf of bread. So you now owe us $100. What? What? And yet, in healthcare, is the time when we so often, or patients so often, facilities so often accept that. It is up to us to make sure that these processes are followed the way they need to follow. And this is part of our job. Medical necessity, it is also our job. We do not question physicians, but we have their back. And it's important that we have a good relationship with the physicians and the providers in our facility to ensure that everything is documented. So we must make sure that according to the standards of care, yes, you need to know that. According to the standards of care, we do not have documentation that establishes this patient really needed to have this procedure or even be admitted into the hospital. When this is done before the claim is sent, before everything gets into an issue, that's when we need to do our jobs. And we need to go back to the physician and query the physician and say, what you wrote here does not support, it does not justify. I'm not saying that. So we're sure that you just forgot to write it down. So we need you to write it down. So everything, we have to dot the I's and cross the T's. That is our job. Contract management. This has to do with denial management, as I mentioned before. If a claim is denied, we don't just, it's not right to just pass along the bill to the patient. We need to find out what went wrong in our process because we're the ones who created the claim. Maybe a code was put in improperly. Typos happen. But that's no reason why Mrs. McGillicuddy should have to pay $3,000 out of her pocket because your coder or your biller made a typo, an entry error, and nobody bothered to check it. Steerage is an important word or term, and you need to understand that this is when the insurer provides financial incentive or a discounted rate to obtain a flow of patients it would not otherwise receive. And, if you ever watch old movies like the Titanic, if you ever saw the Titanic, steerage, that's the cheap seats, okay? These are all analysis of payment variances has to do with the fact that it is known that Medicare may pay you $20 for a flu shot, but Blue Cross Blue Shield may pay $25, and Aetna may pay $30. It is your responsibility to understand these variances. And of course, account collections and postings. Postings means posting the correct amount of whether it's a discount, whether it's a payment from a third-party payer, a payment from the patient. It all has to go to the right place at the right time. All right, case management overall includes a wide scope of clinicians and members of the healthcare industry staff as well as the community, because this is a collaboration that enables us to care for the patient not only while they are in our facility, but after they are discharged. This is not the right industry to say, okay, thanks for coming, bye-bye. And as soon as they cross that threshold, they are no longer a concern of ours. No. So understand what case management involves and who it involves. Utilization management. You know, this is interesting because I used to think that utilization management had to do with utilization of the resources within the facility. Are you using the equipment sufficiently? Is your assignment of healthcare professionals, their staffing? Do you have 10 nurses sitting around in one department doing nothing while you have 3 nurses covering 22 patients in another area? But in our industry, utilization management, also known as utilization review, is focused on, is the hospital admissions policy being utilized properly? In other words, is there documented medical necessity for admitting this patient into a facility, that this patient requires around the clock nursing, professional nursing care, and other healthcare support? That is what a utilization review has to do with, is the validity of a hospital admission or admitting a patient into the hospital. Does the documentation prove this patient requires that level of care? Charge capture. You know, it's so easy to do tasks that are involved, especially in a busy unit, um, and have the little things be missed. But remember that every little thing not only may be another dollar of revenue, that little thing may be supportive of other transactions, of other procedures or care. And so therefore we have to make certain that the methodology used in the facility for recording, in other words documenting, and don't forget that documenting used to mean pen on paper. Now documenting means fingers on a keyboard. Okay. We have to make certain that everything is being collected, the data is being collected completely, as well as efficiently. Okay, case mix index has to do with the types of patients, or I shouldn't say the types of patients, really the types of diagnoses that the facility is providing care. We look most often to the DRG mix, the weights, comparing to each other to make sure that there is not an uneven balance in the average cost to care for patients with inpatient care, as well as, and this goes back to the other kind of utilization review, which is actually utilizing human and physical resources. Revenue cycle days. These are 2 terms that you do need to understand and know. DFNB stands for discharged, no final bill. And that means the patient was discharged, but perhaps there's information lagging, there's data lagging for some reason. It might be from a business associate, it might be from an ancillary aspect of the organization. But there may be cases where there are whole days. It also could be that the physician, even though they did their discharge summary, they may not have um, dictated all of their notes yet, whatever it might be. AR stands for accounts receivable, and this is measured in the number of days between the provision of services and the receipt of payment. Okay, not from the creation and submission of the claim form to the receipt of payment, but when did you do the work, and then how are you getting your money paid? Okay. Reimbursement. Oh, look at all of these different types of third-party payers, and that's why we use that generic term, third-party payer. It is important that you become familiar with all of the places from which a hospital may get money. And also familiarize yourself with these aspects of reimbursement determination. And the word determination, I mean, sometimes it sounds so stuffy, okay? But basically, it means the regular English word. It means that whoever is going to give you money has to first decide if they're going to give you money, and then for what are they going to give you money, and then how much are they going to give you. And that is all wrapped up in all of these aspects. So make sure that you become familiar with all of these elements on those bullet points. Accreditation, a hospital in particular must make certain it is accredited. Now, if you're not aware, for example, you'll notice the third bullet, a state licensure, you're not opening without that. Okay. Certification for Medicare participation. If the hospital doesn't accept Medicare patients, they are carving out a whole lot of population for whom they will not be able to provide service, which means for whom they will not be able to be reimbursed. But this third bullet is the one I really want to mention to you, and that's the voluntary accreditation of the Joint Commission. It is voluntary that hospitals become accredited by the Joint Commission. There is no law that says they have to. However, yeah, the state as well as national government agencies will determine whether or not they will let a hospital stay in business and bill them based on Joint Commission accreditation. So, yeah, you might be able to have patients come into your facility and provide care to them. But if you're not Joint Commission accredited, you may not be able to actually send a claim to Medicare or Medicaid or Blue Cross, Blue Shield, or Aetna or anyone else. So that means that the only patients you can allow in your front door are going to be cash patients. Very small part of the population. Okay, DNV stands for Det Norske Veritas. This is one of the world's leading certification bodies in management system certification services. Google it, look it up in your Oates Waters textbook. Just understand what it is. It's not anything that you have to really learn about intensely, but when you see either DNV or Det Norske Veritas, you want to be able to connect the dots in your brain. RACs, Recovery Audit Contractors. They are contracted with the government, CMS, to check and double check money that the facility has received to ensure that every penny the facility has received was properly earned. They are charged with identification of overpayments. Oops, we gave you too much money and we're taking it back, plus a whole lot more. Or identification of underpayments. Oh, look, you only asked for $10, but you really earned $15. Okay, not a whole lot of those. All right. They are very important. Know what they are, know who they are. You don't have to know specifically their names or the regions, just an overview. Chart reviews. This is something we do now as well, for a while. Identifying incomplete records when there are parts of a patient's record that are not there, such as missing physician's notes or maybe missing lab results. We see an order for a lab. We see that the blood was taken, but there are no results. That is health information management's job. And in the last couple of years, we have also added clinical documentation improvement to these chart reviews. This is very important. And the health information manager is the one who can actually pull permission for a physician to see patients in a hospital if they have too many deficiencies. This will mess up accreditation with the Joint Commission, and then the ball rolls and avalanches. This is all in our purview, and you need to understand that. Point of care. This has to do with the ability and access of those who are bedside, those who are on the floor, to be able to access patient records as well as enter data, because that's the most efficient way to do this, okay? We also have what is known as the continuous record review to ensure that qualitative analysis is being done while the patient is still in the facility. In other words, not waiting until after discharge and have the whole entire record be turned over to HIM for coding and billing, etc., but while the patient is still in the facility, still under active treatment. Code sets, know what they are, know what they do. CPT, HCPCS Level 2, ICD-10-CM, which is very different than ICD-10-PCS. Know the difference. Coding quality assessment is so incredibly important, and you need to know what the baseline measurements are, as well as benchmarks for improvement. Fraud is a bad, bad thing. Note that the Federal False Claims Act, which has little sisters in every single of the 50 states, states have false claims acts as well, and they all have this one very important phrase: anyone who knows or should know a misrepresentation. This means inaccurate codes, unspecified codes, assuming, interpreting, guessing. Okay, there must be a process within your facility headed by you to stop fraud, prevent fraud, and catch any fraudulent activities before anyone else does. CDI, by now you should know this stands for Clinical Documentation Improvement. It is designed to make sure, that the clinical documentation that we work with, that's the health information, that is complete and accurate. And if it's not, it is up to us to get it that way, not make it that way, get it that way. Query programs, helping and educating physicians to understand what we need to know, what the details are that are within our scope that need to be documented. Criteria for quality clinical documentation. Legibility, well, thank goodness, a lot of this is now being done by computer, so we don't have to deal with legibility. But it is still on the list, and you still need to recognize it. Reliable. We need to make sure that we can trust the information, and it needs to be precise. Half-truths don't work. Partial diagnostic statements or procedures, not working. We need to make sure it is complete, consistent, not contradictory, clear, no unambiguous. We want unambiguous, no ambiguous statements, that it's understandable, it's not vague, and it's timely. You know, I know you're busy, doctor, whomever, but dictating notes of a patient you saw 3 months ago, how can I trust that? You've seen 400 patients since then. How could you possibly be accurate and complete? Here's the other thing. We need to help the physicians and the clinicians do this. And good legal queries. You need to understand the components of a good legal query and make sure you're familiar. Any questions? Well, post to our RHIA exam prep discussion forum, and then we can talk it through.